Good morning. It's great to see everyone for another high-impact day here at Spring Clinical Meetings. I'm Julie Ciala. I'm the 2026 Program Chair. I hope you've been enjoying the meeting, finding some time to re-energize connections with colleagues and recommit to kidney health. Just a few chair notes before we get started. I'm sure you've heard this in other sessions, but make sure you download the NKF Meetings mobile app if you haven't done so already. Pre-test, post-test, and evaluations are available in the app, and you can complete those on site, so you're ready to get your CME credit and not take any work home with you. Presentation slides are also available on the mobile app for most presentations, depending on faculty permissions. We encourage you to share your experience at SCM on social media with the hashtag NKF Clinicals, and consider joining NKF if it's not already your professional home. Great. So this morning, it is my great pleasure to introduce you to the 2026 J. Michael Lazarus Distinguished Lecturer, Dr. Ron Wald. This Lazarus Award was established in 2011 to honor Dr. J. Michael Lazarus for his major contributions to clinical science and care of dialysis patients, and to recognize individuals whose research has yielded novel insights related to renal replacement therapy. Dr. Ron Wald is a nephrologist at St. Michael's Hospital in Toronto, Canada, and medical director of the hospital's hemodialysis program. He is also a member of the Department of Nephrology and Hypertension at Tel Aviv Sourasky Medical Center in Israel. He is a professor of the Department of Medicine and in the Institute of Health Policy, Management, and Evaluation at the University of Toronto. A native of Montreal, Dr. Wald completed undergraduate and medical degrees at McGill, I'm so comfortable this morning, at McGill University, and continued his clinical training in internal medicine and nephrology at the University of Toronto. This was followed by a Master of Public Health at Harvard University and a research fellowship at Tufts Medical Center in Boston. Dr. Wald's research areas are in critical care nephrology and maintenance dialysis. He served as co-principal investigator of the START-AKI trial, an international trial on the timing of renal replacement therapy in critically ill patients with acute kidney injury. He's co-leading other trials looking at fluid management in patients with AKI, the PROBE fluid trial, and the optimal dose of RRT in AKI, the WISDOM trial. In the realm of maintenance dialysis, he is on the leadership team of the multinational phosphate trial that is evaluating whether intensive lowering of serum phosphate reduces the risk of major adverse cardiovascular events. So please join me in congratulating and welcoming Dr. Ron Wald.
Thank you, Dr. Ciala, for the extremely kind introduction. I'm very grateful to the Program Committee and to the NKF leadership led by President Kirk Campbell for bestowing this incredible honor on me. I also want to extend a huge thanks to the Program Committee and to the amazing NKF staff, as always, for organizing such a wonderful meeting. The spring clinical meetings are truly the highlight for anyone involved in the care of patients with kidney disease. These are my disclosures. I want to start with a few words about Dr. Lazarus. I never had the privilege of meeting or working with Dr. Michael Lazarus. I spoke to him briefly on the phone yesterday. But an impactful teacher is one whose teachings go down through the generations. And my senior colleague at St. Michael's Hospital, Phil Marsden, as well as my friend and mentor at Rambam Medical Center in Israel, Carl Skorecki, both were fellows under Dr. Lazarus at the Brigham and Women's Hospital in the 1980s. They speak of a physician gentleman with an unrelenting devotion to the care of his patients. He knew all his patients very, very well, and he expected the same of his trainees. A highly charismatic and warm man who was loved by everyone in the dialysis unit. So I'm truly humbled to receive an award that bears his name. I'm also very honored to be counted among the previous winners of the Lazarus Award. This includes several dear personal friends, as well as one of my mentors, Paul Pilewski, who's made an immeasurable impact on my career. Others are individuals who I don't know personally, but I have been inspired and continue to be inspired by their contributions to the field of dialysis. My objectives for today are to take you on a journey, to tell you how conducting clinical trials became the focus of my research career, to convince you that trials in nephrology are necessary for our patients and also exhilarating for us as investigators, and finally, to reflect on the lessons I have learned along the way. So a few words about where I am from. I was born and raised in Montreal. Although Montreal has not been my home for many years, I will always consider myself to be a Montrealer. Montreal is a very vibrant, interesting city of great character, filled with a lot of very interesting characters. The iconic view you are seeing here is from Mount Royal in the fall as the leaves change colors, and the round, somewhat architecturally questionable building in the middle is McGill Medical School. My identity as a physician has been fundamentally changed by my training at McGill, where the education encourages even student doctors, medical students, to take ownership of their patients at a very early stage. But the real education that I got at Montreal was at home. These are my dearly departed parents, Hadassah and Ted Wald, who were immigrants to Canada, but were the ultimate role models for me and my brother. They taught us the values of hard work, humility, and always embraced everyone in our home with warmth and hospitality. And perhaps most relevant to my subsequent career as a clinician researcher, they instilled in me the value of intellectual curiosity. My Jewish identity is central to who I am and is directly linked to why I do research. Judaism encourages asking questions, not merely accepting dogmas. The study of Jewish texts is all about diverse opinions and healthy debate, and like the practice of medicine, it's something that evolves and adapts to new circumstances and realities. Like many Montrealers of my era, I moved to Toronto for residency in 1999. But the most significant thing that happened shortly after I moved to Toronto was marrying my wife, Rachel, now my wife of 25 years, and thank you, Rachel, for traveling for 24 hours from Jerusalem to be here today. My training at the University of Toronto, first in internal medicine and then in the nephrology fellowship program, was very, very unique. We did rotations, actually, at all of the university's teaching hospitals, and as such, we were exposed to the expertise of a variety of people across all the disciplines of nephrology. But the hospital that really became my true home was this place, a scrappy hospital in downtown Toronto called St. Mike's. St. Mike's lacks the fancy five-star atria of a lot of modern-day hospitals, but what it lacks in appearance, it has a lot in terms of character and compassion. St. Mike's is an unabashedly inner-city hospital. It's a place where socially compromised people can sit together in a waiting room near the CEOs of Canadian banks. Senior members of the division at the time included Mark Goldstein, who was probably considered the father of dialysis in Canada, and he instilled in me the love of everything to do with hemodialysis. Mitch Halpern, who sadly we lost this past year, was a wonderful teacher in the area of fluid and electrolytes, and he always challenged us to think very hard about the questions that he was posing and ensure that we always went back to basic principles in physiology. And finally, my division chief, Kamel, uber clinician, immaculate gentleman, and really one of my great friends and supporters in nephrology, who told me that I should pursue a career in clinical research, go wherever I have to go to get the best training, and if I do reasonably well, he'll consider taking me back. So off we went to Boston in 2004, and I was lucky to join the Division of Nephrology at Tufts Medical Center, then known as Tufts New England Medical Center. And I was welcomed by a number of mentors. I had the privilege of working with the energetic and charismatic Brian Pereira, as well as Bertrand Gibert, and they introduced me to an emerging field then of epidemiology of what was then called acute renal failure, now known as AKI. As a young nephrologist at Tufts, a lot of doors were open to me, thanks to amazing mentors like Andy Levy and Mark Sarnak and Dana Miskulin. They helped me get access to the then recently published HEMO trial and allowed me to do a sub-analysis looking at the associations between mineral metabolic parameters and outcomes among patients enrolled in HEMO. And we found that serum phosphate, when it goes approximately above 6, was associated both as a time-varying variable and cumulatively with adverse outcomes. And this work would be a crucial springboard to the clinical trial work that I will tell you about soon. Tufts was also a hub for investigator-initiated clinical trials. I want to emphasize this is important because back then there weren't many investigator-initiated clinical trials in nephrology, and Andy played a central role in the impactful hemo trial. My friend and mentor Ron Perrone was a central figure in a lot of the important trials that were going on in polycystic kidney disease at the time. But the bigger picture in nephrology at that time did not look great. This is a paper that Giovanni Stripoli and colleagues published in 2004, just as I was close to the end of nephrology training. And they demonstrated that among internal medicine subspecialties, we were dead last when it came to clinical trial productivity. So we asked the question, what are the barriers then to conducting trials in nephrology? Of course, there are funding challenges, and it has been well documented that although chronic kidney disease is common and that it's costly, the amount spent per capita on patients on research in kidney disease is well below other disease conditions like cancer and cardiovascular disease. There was another concern relates to how dialysis delivery is structured. And there was a fantastic opinion piece just published online in JSON by Hofstetter and Briggs lamenting the challenges of doing research in the dialysis setting in the United States. The other problem that I think arises sometimes has to do with the fact that although CKD is common, some of the diseases that maybe we view as kind of common are actually relatively rare, especially the glomerular conditions. But then I want to talk about the excuses that we tell ourselves to justify not doing trials. Some people might say, our patients are way too complicated to participate in trials. But aren't oncology patients complicated? Aren't end-stage heart failure patients complicated? There's a lot of great trials going on in those areas. Some will take a moralistic lens and say it's unethical to study questions when a standard of care has already been established. But if that standard of care arose through weak evidence, is it really unethical to open that box and ask the question? And finally, some nephrologists might say that I don't need a clinical trial in order to know what to do. And I call this the confidence-evidence misalignment. As evidence is almost zero, the confidence of physicians on one side or the other of an argument becomes quite prominent, shall we say. So, what are some of the other fallacies that underlie RCT hesitancy in nephrology? Number one is perhaps an excessive willingness to rely on associations that come out of observational studies as the basis for managing patients. And one of the lessons that I hope we've learned has to do with anemia. This was a paper from DOPS published about 20 years ago showing that mortality declines as hemoglobins go up. This is something I think we all kind of have a feel for as clinicians. So, wow, we have this amazing tool called an erythropoiesis stimulating agent. We can dial up that hemoglobin to the normal range, which apparently is healthiest for patients. Well, we know where that story ended, showing that, in fact, normalizing hemoglobin not only is it of no benefit, but could be potentially harmful as well. Another thing that we sometimes do is that we assume that evidence that's acquired from patients with either mild or no chronic kidney disease is good enough to manage our patients. And of course, we have the lesson from statins, which seem to do amazing things for all patients, all patient populations, except, unfortunately, for those patients receiving maintenance dialysis. The 4D trial and the Aurora trial taught us those lessons as well. So after 2 great years in Boston, it was time to go back to Toronto. Luckily, I was welcomed by my divisional colleagues at St. Mike's. And I'm grateful to them, number one, for giving me protected research time, but also for giving me sort of a carte blanche to really answer the questions that I thought were most important. It was also a very, very fortuitous thing that at the time, in the mid-2000s, the Canadian Institutes for Health Research, our equivalent of the NIH, had a mentoring program for young investigators who were interested in doing clinical trials. And I had the privilege of being mentored by Andreas Lopakis, who was a very seasoned and very wise trialist, as I developed my trial programs. The first stop in my trial journey took me to the ICU. Nephrologists spend a lot of time in the ICU as consultants. We interact very closely with our intensivist friends. A significant proportion of critically ill patients receive renal replacement therapy, but there was very little evidence to guide practice in the area of acute dialysis. The KDIGO guidelines in AKI, published in 2012, there's now a new version that's coming out soon. In their section on dialysis interventions for the treatment of AKI, they made 33 statements, of which 14 were merely suggestions and 9 were completely ungraded. So almost the vast majority of the evidence or the recommendations, I should say, in these guidelines were really based on very, very weak evidence. So there's a lot of work to do here. So to take on this challenge of doing research in the area of acute dialysis, you need a few things. And the first step was to find the right partner. This is my dear friend, Sean Bagshaw, currently the chair of critical care medicine at the University of Alberta in Edmonton. Sean has unparalleled energy, a passion for critical care nephrology, and he has very strong and deep relationships with intensivists around the world. We don't live in the same city and rarely actually see each other in person, but our collaboration has been productive and fruitful and meaningful, and I'm very, very grateful to Sean. The second step was to engage with a network. And for 40 years, the Canadian Critical Care Trials Group has been at the forefront of tackling the most vexing questions in ICU medicine. Members of the group get together 3 times a year to discuss protocols brought forth by various investigators and give feedback and also opportunities for collaboration across Canada. Affiliating my research program with the trials group proved to be critical to building a cross-Canada network of sites for the trials that we will be doing. And the third step was to find the right mentors. I have been blessed to have benefited from the mentorship of 3 unique individuals: Paul Pilevsky, who's here today, former president of the NKF, Glenn Chertow, and the late Ronaldo Bellomo. It should be noted that I was never a resident or a fellow at their respective institutions, which is a further testament to their generosity. But Paul and Glenn and Ronaldo saw me as a younger colleague who just wanted to do trials in the ICU, and their first instinct was simply to help and to do so unconditionally. I will never forget a phone call with Paul around 2005, which lasted for an hour. Paul, you'd never met me before, in which he told me about the ins and outs of the ATN trial that was going on at the time, and gave me very, very wise lessons for the design of the trials that we were working on in development at that time. The next step then is to develop an impactful research question. And I think that, to do this is hard, but I think I like to look at these questions as we develop our studies. Number 1, are patients being disadvantaged by the lack of definitive data? Does this dilemma bug me? Am I excited about this question? Because I'm going to have to live with this trial for many years, and I have to keep that excitement up in order to bring it to conclusion. Do my colleagues care about this? Will the results shape practice, whether the result is so-called positive or negative? And of course, we have to ask, what do patients think? So the question that we ultimately settled on was the following: when to start renal replacement therapy in the setting of acute kidney injury in the ICU? Let's look at what the guidelines said on this topic. They told us to initiate renal replacement therapy emergently when life-threatening changes in fluid, electrolyte, and acid-base balance exist. Pretty obvious and probably pretty straightforward. No one would criticize the fact that we should start dialysis if a patient has medically refractory hyperkalemia or severe metabolic acidosis or volume overload or uremic pericarditis or encephalopathy, although that's a hard one to dice out in the ICU. And of course, if there's a concomitant drug intoxication with the AKI, again, legitimate reasons to start dialysis urgently. But these are scenarios that aren't the typical ones that drive the decisions around starting dialysis. What about patients with severe AKI in whom none of these complications are present? And here, the guidelines are a little bit vague. They tell us to consider the broader clinical context, the presence of conditions that could be modified with renal replacement therapy, the trends in laboratory tests when making the decision to start. So deliberately very vague advice that was given at the time. And in fact, there were 2 diametrically opposed camps on this topic. In 2012, John Kellum and colleagues published a very provocative opinion piece in JAMA called Kidney Attack. The premise of this paper was that we as nephrologists should view acute kidney injury analogously to the way cardiologists view myocardial infarctions. Myocardial infarctions are all about great biomarkers, early detection, getting patients to the cath lab quickly, intervening aggressively. Our fault as nephrologists, they would argue, is that we've been too passive about acute kidney injury, and we need to adopt that cardiology model into our daily practice. And there was a lot of good rationale for starting dialysis earlier or preemptively. We know that dialysis will provide more reliable achievement of volume control, quicker restoration of acid-base homeostasis, the removal of small and middle-sized molecules, perhaps mitigating the inflammatory milieu. But on the other hand, it's important to be cautious about a strategy preemptive renal replacement therapy. Many patients, we know this from our practice, many patients with even the most severe AKI will experience kidney recovery without any dialytic intervention. And dialysis is not benign. When you start someone on dialysis, of course, there's the risk of dialysis itself and the risk of an extravascular access. So what is the question that an RCT needs to answer? Basically, we formulate it as follows. In critically ill patients with AKI, does a strategy of accelerated or preemptive initiation of renal replacement therapy as compared to a strategy of watchful waiting and initiation of renal replacement therapy in the setting of a pressing indication reduce 90-day all-cause mortality? What would such an RCT look like? Essentially, we would want to identify adults with severe AKI with no current urgent indications for renal replacement therapy, like severe hyperkalemia or metabolic acidosis. Our intervention would be accelerated dialysis, whereby dialysis is started as soon as possible. In our control arm, we would defer renal replacement therapy until an indication becomes apparent. Our outcomes primarily would be 90-day all-cause mortality, and also very important, how many of those survivors to 90 days would be still dependent on renal replacement therapy. Using a lot of acronymical license, we called our trial START-AKI, which stands for Standard versus Accelerated Renal Replacement Therapy Initiation for AKI. So, having defined the question and kind of sculpted the overall design of the trial, how does one set the stage to do a definitive trial to answer this question? Number one, we conducted a meta-analysis of the existing literature. We did background work to help define the standard of care. We surveyed our colleagues to make sure they would be willing to participate in a hypothetical trial. But most importantly, probably the penultimate step before going to a major definitive trial is to do a pilot trial. The purpose of pilot trials is as follows. Number one, we want to establish the feasibility, essentially, of implementing your trial idea. Will patients agree to participate? Will clinicians agree to let patients participate? Is the study idea fundable? And is the sample size feasible to attain? And the reason you must do pilot trials, in my view, is you can have the best research question ever, but you could be ultimately left with a trial that is difficult to implement due to feasibility issues. So for START-AKI, we did conduct a pilot trial of about 100 patients across 12 Canadian centers in 2012 and 2013, and showed that, yes, we were able to recruit patients. These patients that we wanted to recruit for the big trial existed. We were able to recruit these patients in about a year and a half, which was pretty good. We were able to demonstrate a separation in terms of dialysis start time in the earlier versus the later group, and we were able to follow almost all patients to 90 days. So with that, we thought we were ready to go with the definitive trial. But before launching the main trial, several challenges still remained. We determined that a definitive trial would require about 3,000 participants. And Canada, although geographically large, is population-wise too small to support recruitment at this scale. So the scope of the trial would have to be diversified. So we called a friend. In fact, we called many friends. And we were very, very honored that so many colleagues around the world stepped up to participate. 15 countries and 168 sites participated in START-AKI. And many of our colleagues around the world, particularly those in the UK, Australia, and New Zealand, actually obtained government funding to support START-AKI. So this is really an international trial with joint funding from multiple funding sources. So what did we actually do in the trial? Well, if a patient who was eligible was randomized to early or accelerated renal replacement therapy, the answer was start renal replacement therapy as soon as you can, but no longer than 12 hours after he or she becomes eligible. On the other hand, in the standard arm, we took a completely different approach. We recommended that renal replacement therapy not be started unless one or more of the following was present: significant hyperkalemia, severe acidosis, severe hypoxia that is felt to be mediated by volume overload. And if a patient still had unresolving AKI at 72 hours after enrollment with none of the aforementioned indications, it was up to the clinicians to decide for themselves whether they wanted to start or not. The primary outcome of START AKI, as mentioned, was all-cause mortality at 90 days. The typical patient in the trial was a man in his 60s. Many patients had underlying chronic kidney disease. The most common context for AKI was sepsis, not surprisingly. Most patients were mechanically ventilated on pressors. Most were oliguric or borderline oliguric. And what did we find in the trial? We found actually that accelerated renal replacement therapy had absolutely no advantage as compared to a standard strategy, 44% mortality at 90 days in both arms. In terms of our secondary outcomes, one of the more provocative outcomes related to the degree of dialysis dependence among survivors at 90 days. Here we found that there were significantly more patients who were still on dialysis at 90 days in the accelerated arm as compared to the standard arm. The bottom line from START AKI was as follows. A strategy of earlier renal replacement therapy initiation does not mediate better survival. Earlier renal replacement therapy initiation has potential adverse effects, in particular the concern about greater dialysis dependence among survivors. And so in patients, even with the most severe AKI with no urgent indications for renal replacement therapy initiation, there is no urgency to start renal replacement therapy. The KDIGO 2026 guidelines, which are still in the public arena for discussion, recommend actually that for adults with AKI, a strategy of deferred timing of renal replacement therapy initiation is preferred. Again, this emanates, I think, from the START AKI trial, as well, I should mention, as other trials that were done in this area at around the same time. Running START AKI, though, taught us many lessons, aside from the science behind the trial. I think we showed, as Paul and people in the ATN group, and as well as colleagues in New Zealand from previous trials showed as well, that critically ill patients could be successfully recruited and randomized to a time-sensitive intervention involving renal replacement therapy. Geography should never be an impediment to conducting trials. It's also important to diversify your sites, and we engaged a lot of community hospitals that prior to that had not done much research, but they embraced START AKI wholeheartedly and made a huge contribution. So we learned that it's really important to always have hospitals that are so-called academic and hospitals that are perhaps less academic, but the passion for research still exists in those community hospitals. START AKI was also a great opportunity to make new friends and establish a network. Sean and I traveled a lot in those days around the world to meet colleagues, and these were pre-COVID times, and luckily we finished the trial just before the onset of COVID. But we met a lot of wonderful people, and these colleagues became the nidus for a network of investigators who would participate in other trials involving renal replacement therapy in the ICU. And so currently this collaboration from START AKI is helping to support the Ultra AKI trial, which is looking at albumin in the setting of acute dialysis. The Wisdom trial, which is looking at whether a lower dialysis dose than the current standard is just as good. Recover AKI, looking at strategies for weaning renal replacement therapy, and Probe Fluid, examining ultrafiltration strategies in patients with AKI in the ICU. I want to shift gears now to talk about the work we are doing in the area of maintenance dialysis. About 500,000 Americans receive maintenance dialysis. Their quality of life is challenging. Outcomes are not where we want them to be as their physicians. And perhaps one of the reasons for this is the fact that practice in dialysis is often not rooted in high-quality evidence. There are very few large-scale investigator-initiated trials that have been conducted. And one area of particular controversy in modern nephrology is how to manage serum phosphate in patients receiving maintenance dialysis. We all know that hyperphosphatemia is ubiquitous in maintenance dialysis patients, and phosphate is found in many parts of our diet. As kidneys fail, intake exceeds the ability to excrete the phosphate load, and while dialysis does remove phosphate, conventional dialysis regimens will still leave patients with a net gain of phosphate. Should we worry about this? Apparently, we do worry about it. And these are two really nice review articles that appeared in the nephrology literature about a decade ago. And nephrologists, I think we tend to be relatively mild-mannered, non-dramatic, but here they're calling phosphate a poison for humans, a killer. And the question is this concern actually warranted? Well, I think there's a lot of important basic science data to highlight the fact that hyperphosphatemia may indeed induce vascular calcification. This is work by Jono and colleagues showing that when you immerse vascular smooth muscle cells in a high phosphate medium, calcification is dramatically increased in these cells. And as the gradient of phosphate increases, so does calcium deposition in and around these vascular smooth muscle cells. And there's a lot of epidemiologic data to support the fact that higher phosphate levels are associated with bad outcomes. This is a meta-analysis from JAMA 15 years ago now by Palmer and colleagues showing that for every unit increase in serum phosphate, you have an 18% increase in mortality. And looking at cardiovascular mortality, for every unit increase in phosphate, you have a 10% increase in mortality. So very compelling data to suggest that perhaps phosphate is indeed dangerous for our patients. Lowering phosphate, therefore, makes intuitive sense, because if high phosphate is associated with mortality, you would think then that lowering phosphate concentration would reduce mortality. If phosphate causes vascular calcification, then lowering the serum phosphate concentration will prevent vascular calcification and maybe reduce cardiovascular events. And finally, if phosphate is damaging to bone and induces pruritus, then lowering serum phosphate will protect bone health and maybe lessen uremic pruritus. All seemingly rational things to say. However, the big however is that association does not necessarily mean causation. And there has never been a trial showing that deliberately lowering serum phosphate leads to better outcomes. We also have to keep in mind that lowering serum phosphate is extremely challenging, both for us, but moreover for our patients, because it means subjecting patients to a restrictive diet. It means sometimes the need to intensify or increase the number of days on dialysis, something that many of our patients are not willing to do. And finally, we have to achieve good phosphate control, it often means that we have to prescribe more and escalate the doses of phosphate binders. And these are all problematic for our patients in various ways. The other problem in the phosphate world is that the really nice high-impact trials that have been done in this area have been dominated by how rather than if serum phosphate should be lowered. So the Treat to Goal trial showed that sevelamer, as compared to calcium acetate, reduces vascular calcification progression in dialysis patients. The DECOR trial compared sevelamer and calcium and actually showed no mortality advantage of sevelamer. And the Landmark trial compared lanthanum and calcium in dialysis patients in Japan and again showed no advantage of lanthanum. All very important trials, but they again didn't come to the fundamental question of should we even lower serum phosphate aggressively? A recent Cochrane review by Natal and colleagues actually said something very dramatic. Their bottom line was that there are no clinically important benefits of phosphate binders when it comes to impacting cardiovascular death or coronary artery calcium score as compared to placebo. So there's a fundamental question from the body of trials that is in the literature as to whether phosphate binders do anything for patients in terms of impacting on cardiovascular health. Nonetheless, the KDIGO guidelines, with a big caveat, tell us that in patients on dialysis with CKD stage 5D, they suggest lowering elevated phosphate levels toward the normal range. And by and large, that is what we have been influenced by over the years. So the essence of the phosphate dilemma is as follows. If high phosphate concentration is just a number, or is it something dangerous for patients? If it's just a number, then maybe we can just accept it as a fact of kidney failure and move on. But if it's something that represents something dangerous for patients, then we must do something about it. And so the fundamental dilemma in the world of hyperphosphatemia is, do we normalize or do we liberalize? And the only solution is a well-designed, adequately powered RCT to test whether phosphate normalization as compared to tolerance of higher phosphate concentrations reduces cardiovascular morbidity and mortality among maintenance dialysis recipients. So to do this, again, I identified a wonderful partner, Mike Walsh from McMaster University, and together we brought together a few Canadian centers to do a pilot trial called Target, in which we compared a liberalized approach to phosphate control, where we withdrew phosphate binders, and a more intensive approach. The trial only went on for 26 weeks, but we showed that we were able to obtain a 0.5 millimole per liter separation between the two groups in terms of phosphate concentration. And from there, we moved on to phosphate, which stands for Pragmatic Randomized Trial of High or Standard Phosphate Targets in End-Stage Kidney Disease. We initially partnered with wonderful colleagues in Australia, New Zealand, and the UK, and then expanded it to Thailand and Brazil, and France and Israel and Singapore and Denmark. And phosphate is an open-label, investigator-initiated, multinational pragmatic RCT comparing intensive and liberalized serum phosphate control in patients with end-stage kidney disease receiving dialysis. And the fundamental question of phosphate is whether intensive phosphate lowering, as compared to a liberalized strategy, confers a lower risk of fatal and non-fatal major adverse cardiovascular events in patients with kidney failure receiving dialysis. Who are we recruiting? We're looking for adults on dialysis for at least 3 months, PD or hemo, both acceptable. You have to be either 45 years of age or older. If you're diabetic, anyone over 18 can participate. And they have to be prescribed at least one phosphate-lowering medication. We're excluding individuals, we're not excluding many individuals at all. If the patient has an elective transplant scheduled in the next 6 months or is felt to be at high risk of dying in the next 6 months, they're excluded. And if they happen to be participating in another trial that may impact upon serum phosphate levels, they would be excluded as well. This is an algorithm of kind of how we manage the trial. If the patient's in the intensive arm, we want to get that patient's phosphate to between, I'm going to use the American units, 2.3 to 4.65. But if they're above 4.65, we will work with the patient and the dietitians will work with the patient to help get their phosphate restriction optimized. We will do our best to get their dialysis prescription optimized, and as needed, if the patient accepts it, we will escalate phosphate binders. In the liberalized arm, once a patient is randomized, we tell them to stop all binders, cold turkey, right after randomization. And we're aiming to keep patients in the range of 6.2 to 7.7 milligrams per deciliter. And often, we found in this trial that even if patients are off binders, frequently their phosphates are below 6.2, in which case we actually don't do anything. We are just kind of happy with the fact that they're off binders. How do we do this trial? Well, we have research coordinators at all the sites, but the actual day-to-day activities of the trial are carried out within the context of usual care by the usual clinicians who manage phosphate in the dialysis unit. We as a research team provide reminders, but the ultimate titration of phosphate is really done by the local clinicians. All accessible phosphate binders may be used. Dietary advice and dialysis optimization intensification are definitely an important part of the intensive arm as well. And we don't do any extra blood work or any extra tests. We only use routinely collected blood work to guide titrations to achieve the desired phosphate targets. The primary outcome are major adverse cardiovascular events, a composite of cardiovascular death, non-fatal MI, coronary revascularization, non-fatal stroke, or a peripheral arterial event. The trial has recruited well. We've recruited over 3,600 participants to date. We hope to conclude recruitment at the end of this year and conclude follow-up at the end of 2027, and hopefully, don't quote me, hopefully announce the results in 2028. Similar to START-AKI, in addition to the science of the phosphate question, phosphate has enabled the creation of an international network of RCTs and dialysis. On the left are my colleagues in Brisbane at the Australasian Kidney Trials Network. The two photos on the right side are my friends in Brazil, and in the bottom right corner is the recent activation meeting we had on Zoom with our colleagues in Singapore who just recruited their first patient this morning. So I want to conclude now with 10 lessons that I have learned by conducting trials in nephrology. and in no particular order. Number one, I would argue that impactful research has to start at home. This is a picture of our dialysis unit, and below our research coordinator, Ivana, talking to our nurses about the trials that we're running. I think it's really important to establish a culture in your unit where research is intertwined with clinical care. Patients need to be educated about why research is important and how it can change their lives. We have to foster enthusiasm for research among clinical staff and convince hospital management that research is not just an academic distraction. It's essential to providing great care. And I would argue that units that conduct a lot of clinical trials, excellence in care actually increases because of all the extra attention we give patients as a result of those trials. It's important to establish a local team of investigators on whom you can depend. I have two local teams, one in Toronto with my friends Anne Young, Ziv Harel, and Jeff Pearl. We work very closely together on our research endeavors. And in Tel Aviv, Ori Kluk and Hila Sodentorp and Lena Kaufman, our team in Tel Aviv. I also feel very strongly that physicians should not be the only clinicians who do research. In our unit, we encourage all interested clinicians to formulate questions about which they feel passionate and lead studies on them. And this is an example of one of them. Alison Thomas is a senior nurse practitioner in our program, and she was troubled by the fact that we have this tradition in nephrology of doing blood work on a monthly basis. And we found that some centers in the province of Ontario do blood work every 6 weeks. And when we compared outcomes in those units that do blood work every 6 weeks to those that do the traditional monthly blood work, we found no difference in mortality. And Alison's paper was published in AJKD about 6 years ago. I also want to highlight the work presented at this meeting by Leora Wanunu, one of our senior nurse practitioners, who was intrigued by the concept of volume overload and how frequently it occurs when dialysis patients return from hospitalization. And she had a great presentation about this yesterday. And Arthi Parpia, one of our senior dietitians, who was intrigued by the content of phosphate and potassium in everyday snack foods that we Canadians consume in our daily living. I think it's absolutely vital to nurture the growth of research professionals. Research coordinators are the key to success of any trial. Our group's philosophy is to choose the best people and empower them to take initiative and embed them in our clinics and dialysis units. Ivana Perche is our research manager and the engine of our research program. Her excellence is not merely reflected in the fact that she performs all the routine tasks of research well, but she is totally imbued with the essential idea that research is a mission and research coordination is a calling where the patient is at the center. Ivana creates excitement about research among staff and patients, and this is the team on the right that she's put together: Janice and Samaritan, Anna Jo, and Isabella. I'm blessed as well that my ICU colleagues let me work with the amazing coordinators in their unit. Doing research in the ICU and convincing patients in the ICU to participate in clinical trials is extremely hard. I would argue, though, that the coordinators who do this well are really artists. And Erin and Marlene and Guyan are tremendous recruiters in the ICU. They know how to speak to patients, usually it's their families, and recruit well and help us answer important questions in the ICU. I think it's absolutely vital to demonstrate personal engagement. As the overall PI for a trial, it's vital for you to be 100% committed to getting the trial completed. This can't be done from the comfort of your office. You've got to be in the dialysis unit, in the clinic, in the ICU, wherever the trial is taking place, and project enthusiasm about the trial to patients and to staff. I always try to be available all the time to investigators and staff at all our sites, and no detail is too trivial. I always encourage people to contact me with any questions they have. When I'm asked by colleagues to serve as a site lead for a trial that they might be leading, my default is to say yes. And we have to say yes because impactful trials require multiple productive, invested centers. We have to treat trials that others are leading with the same passion as the ones that we are leading. We need to strive to recruit as many patients as feasible and remember that getting answers for our patients should transcend academic credit. Don't be afraid to fail. And I've had, trust me, many research disappointments, grants that went unfunded, trials that proved to be infeasible during the pilot phase, time that was seemingly wasted working on something that didn't go anywhere. But all of these disappointments were really sources of learning and growth. And research, like almost anything in life, in research you have to take risks, otherwise you can't move things forward. I think it's also really important to spend time to invest in the next generation, just like my mentors invested in me. And I want to highlight the work of several colleagues of whom I'm extremely proud, working in our group, who are answering really vital questions in the area of nephrology. Ziv Harel, a nephrologist in our group, is embarking on a trial right now to answer whether oral anticoagulation reduces the risk of stroke in maintenance dialysis patients who have atrial fibrillation. Arthi, who I mentioned earlier, is about to embark on a trial that will assess whether a liberalized potassium diet is safe as compared to a standard diet in patients receiving maintenance dialysis. William Beaubien-Souligny, a nephrologist in Montreal, is looking at whether a strategy of aggressive ultrafiltration hastens clinical improvement in critically ill patients with AKI who are receiving renal replacement therapy. And finally, Kevin Yao, a nephrologist at Toronto General Hospital, is highly intrigued by all the data that's come out about semaglutide in patients with chronic kidney disease. Unfortunately, those trials excluded those on dialysis. And so he's embarked on a research program that will answer whether semaglutide also reduces major adverse cardiovascular events in maintenance dialysis recipients. It's always important, maybe easier said than done, to stay positive and ignore the naysayers. Trials are roller coasters with numerous mini crises that arise. Will we run out of funds? Is recruitment slowing down? It's important not to let problems fester, to be prepared with practical solutions, and ultimately remain focused on the big picture, which is answering important questions for patients. And finally, on that note, we have to remember why we do research. These are my patients, both in Toronto and in Tel Aviv, who agreed to be photographed. These are the people for whom we are doing this research, to give them better outcomes with better evidence. None of this would be possible with a few key people in my life. Rose Hulins has been my administrative assistant for the entirety of my career. She runs our office efficiently, effectively, most importantly for our patients, compassionately. And I'm extremely grateful for all that she's done for me over the years. And finally, my family, my wife Rachel, my children Benji, Zach, Josh, and Tamar, their unwavering love, their constant support, and their immeasurable patience with me enabled me to do all this. I want to thank all of you for your attention. Happy to answer questions.
So thank you so much for a really inspiring lecture and your commitment to people with kidney disease and getting important answers. We would like to present you with the Lazarus Award on behalf of the National Kidney Foundation.
Thank you.
We do probably have time for one or two questions. If anyone has a burning question, is welcome to come to the mic.
Has the industrialization and financialization of dialysis in the United States affected your ability to recruit centers and collaborators?
I would say that I want to first begin by saying we have incredible collaborators south of our border, that's Canada, who have participated in START-AKI. I will say that the challenges really evolve around the costs of running research in the US, which are far higher than they are in Canada and actually in most parts of the world. I think that has been a barrier. That hasn't, however, prevented wonderful colleagues like Ashita Talwani and Javier Neira and Kianush Kishani at the Mayo Clinic to still participate and make really meaningful contributions to START-AKI and other studies that we're doing. But that definitely is a barrier for sure.
Thank you.
Thank you for that really inspiring talk. I had some questions about the phosphate, the ceiling of the phosphate level in your trial. I think it was 7.8 or 7.9. Was that based on clinician consensus? Was it a meta-analysis that showed a threshold that led to associated bad outcomes?
So in In the SI units, 7.7 translates to 2.5 millimoles per liter, so it's kind of like a nice round number. There's a bit of arbitrariness there. I think we felt that that was a level that clinicians might begin to feel uncomfortable letting the phosphate rise above. And it was kind of a feeling, discussions with colleagues, nothing that was formulated. We certainly know from observational studies that there's an incremental rise in bad outcomes as the phosphate goes up for sure. But the number of 7.7 was ultimately somewhat, there's a bit of arbitrariness to that choice for sure.
Okay, thank you.
Thank you again.
Okay, thank you so much. Appreciate it.
This concludes our session this morning. We invite you to please attend many of the exciting sessions. We have patient-centered communication, innovation in kidney disease, just to name a few. Trainees, please attend our high-yield board review at 4:30. Thank you.